I really appreciate everybody getting up so early on a Saturday morning, especially when we're probably going to boogie into the night. But my name is Sharon Walmsley. I am the co-director of the CTN Plus, and I would like to thank you for joining us for our postdoctoral symposium. As many of you know, the network has pioneered a cutting-edge clinical research that places community priorities and perspectives at the forefront. But one of the really great things about our network has been our postdoctoral fellow program. And we really have had a number of young investigators over the years rise to the front, tackle some of the important problems that are facing HIV and STBBI in Canada. We're very thankful for all of our mentors that have helped our young investigators over the years launch their careers, and we're very thankful for our many sponsors that have helped us to support these postdoctoral fellows. So for the past 30 years, we've now had in total 120 early career researchers who are now defining the new face of HIV and STBBI research. Today, we're going to learn about who are going to be our new postdoctoral fellows, and we'll hear from 3 of our second-year postdoctoral fellows about the projects that they are bringing to completion. This work is really integral to our continuing to fight the HIV epidemic. So, HIV research is not dead. And unbelievable the number of applicants we had for the postdoctoral fellow program for next year. And our adjudication committee had a real daunting task in order to come up with the winners. But I'm very happy to announce that we are actually going to have 6 new postdoctoral fellows next year. And I'd like to just make their announcement, and if they're here, they could raise their hand and we can all give them some congratulations. So the first one is Nikki Petrikas, who will be supervised by Alexandra DeCommandi from McGill University, and they will be working on the real-world impacts of primary cardiovascular prevention and HIV care. Are they there? Perfect. The second one is Fatoumata Tunkaha, supervised by Valerie Martel-Lafayette at CHUM. Their project will be on HIV prevalence, cervical cancer screening, and post-screening care among women who use drugs in Montreal. Oh, it's over there. Perfect. Our third winner is Tejan Bajan, supervised by Sahir Sahid at Queen's University. We'll be working on a Bayesian analysis of factors affecting diagnostic accuracy of point-of-care syphilis testing in the Canada Public Health units. Congratulations. The next is Emma Cooley, who will be receiving the Mark Weinberg Fellowship and will be supervised by Marina Klein at McGill University and be working on ART-associated cardiometabolic disease and healthy aging in people living with HIV. Congratulations. The next is Mark Parsons, who will be supervised by Guillaume Fontaine at McGill University. He will be working on the hybrid type 2 effectiveness implementation cluster-controlled trials of long-acting PrEP for HIV prevention. And not but least, our last winner, Shinya Nizan, supervised by Rusty Suleymanov at the University of Manitoba, will be investigating PrEP use awareness, perceptions, barriers, and facilitators among African, Caribbean, and Black communities in Montreal. So congratulations to all of our new winners and all of their mentors, and we look very forward to hearing the progress of their research going on next year. But we're going to turn the program now over to our current postdoctoral fellows who are going to be sharing with us the results of their investigation so far. So our first presenter today is Dr. Muyi Iyamu, who will be presenting his findings from the Multi-Methods Embedded Health Systems research study examining the long-term sustainability of the BC digital STBBI testing service, GetCheckedOnline. So we welcome you to the podium. Thank you.
Hi, everyone. Good morning. Thanks for having me. Can I have the slides, please? Oh, I have to really press it hard. Okay, this morning I would like to thank everyone for coming up. My name is Muyi. I'm embedded at the BC Center for Disease Control, and I'll be talking about our work trying to understand how best to sustain a digital service for STI testing. I'd like to start by acknowledging with gratitude that we are located here on Treaty 1 territory, the ancestral lands of the Anishinaabe, Ininiwak, Ojibwe, Dene, and Dakota, and the national homelands of the Red River Métis. I'd also like to acknowledge that our drinking water here is sourced from the Shoal Lake 40 First Nations. And finally, I would also like to acknowledge that the work I do is on the unceded traditional ancestral territories of the Musqueam, Squamish, and Tsleil-Waututh nations. I have no conflicts to declare. Here's my funding. So the problem that my fellowship was really trying to address is the idea that, once you've established effectiveness evidence for an intervention like digital STI testing, how do you sustain a service going forward within a complex health system as exists in BC? And this is not a new problem, and it's not isolated to digital services. This Naylor report, which is now quite dated, published in 2015, suggested that we do have a problem with lots of perpetual pilots, but very few interventions actually crossing the threshold to become scaled, integrated interventions. And within the digital sphere, this is even more pronounced because there's this techno-optimistic view of digital interventions where we think that they are the best interventions, we think that they will be, result in best solutions, but after trying them, it's very difficult to actually integrate them at scale. And this is even more pronounced since the COVID-19 pandemic. So evidence from UK, for example, suggested that prior to COVID-19, about 20% of tests for STI were conducted in person or through clinics. But after the pandemic, about 40% of testing then became based on the internet. My doctoral work suggested that COVID-19 was a significant inflection point where testing then moved significantly online, and now we do at least 30,000 tests per year on GetCheckedOnline. And we're seeing that there's a change in the demography of the population that we test through GetCheckedOnline. So, for example, testing older people who are aged over 40. We're testing more among people who are engaging with the health system for the very first time online rather than in person. And there's also concerns around the idea of demand induction, where if there's no gatekeeping from a health service provider, people might test because they're worried, and that's called worried well testing. And so there's concerns that that becomes a pressure point on the health system in terms of sustaining it going forward. The elephant in the room is that we're undergoing quite significant constraints at this current time. In BC, there's cuts to the health system, to reduce budgetary deficits. And challenge is not that the service is not effective. The challenge is how do you maintain the service through its effectiveness within this kind of complex system. And that's the work that I was trying to do with my fellowship. To give context, this is health systems work, so sometimes I feel rather far off left field in a conversation like this among physicians and clinicians and community folks who are really focused on clinical community-based systems. But this work was really propped up by the GetCheckedOnline Sustainment Working Group, who had been set up even before I started my fellowship. It was a group of folks from the Ministry of Health, the health authorities, all serving the systems and required to facilitate testing. And my role was to inform their decision-making and planning for the service going forward. But what we found was that there was very little evidence that helped serve that purpose. Most of the implementation science evidence we have these barriers and facilitators framing, which doesn't necessarily serve the decision-making function we're trying to do here. And so my objective was to first help understand how sustainability challenges emerge over time as digital testing interventions are implemented and scale, and then to generate actionable systems evidence that will inform the long-term decision-making around the service. And I did that through 4 interconnected sub-studies on this fellowship. First was to create a clear description of the service using the core functions and possible forms framework. I'll describe it in detail soon. And then we did interviews with systems partners using an instrumental case study to really understand how people framed sustainability, how that framing of sustainability influenced the current context of the service, and how we can determine strengthening our sustainability packages going forward. The third study really then helped us generate more transferable evidence that can help folks who've thought about implementing digital services like GetCheckedOnline in their own context. And then finally, we try to answer some systems-based questions about the concern around demand induction and whether or not that's actually in place in the service here. So the first one around describing the service. First, I'll just describe what GetCheckedOnline is. I know I've been talking about it for a while. You might not know about GetCheckedOnline. So GetCheckedOnline is a service that's run by the BC Center for Disease Control in collaboration with the BC Public Health Lab and regional health authorities responsible for delivery of health services. It's been launched, it was launched in 2014, so it's been on for quite a while now. In brief, what it does is users can create an account online. They go through a sexual risk assessment questionnaire. They get tests recommended to them. They give samples at partnering labs located in 9 communities where we serve. They get test results online. If test results are positive, they get contacted by public health nurses and then get linked to treatment. And that cycle continues over time. So just giving you a brief about the evolution of the service, GetCheckedOnline, like I said, was launched in 2014, but had gone through a lot of clinical preparation before that since 2009, and has undergone systematic scale-up since then, and now we're in 9 communities. So in this first study, if you're familiar with implementation science theory, what we say is that if you make changes to a program without clearly thinking through it, you might go through what's called program drift, where the effectiveness of the study of the intervention reduces over time because you make unintentional changes. So the first study really focused on clearly laying out what the core principles for operating the service would look like and what then adaptations can look like in different contexts. So it was a 3-stage study. We reviewed existing documents to document the core functions. We then refined these core functions with systems partners and then hypothesized possible forms that it could be implemented in different contexts, whether in rural, remote, or in urban settings. And then we consolidated that using existing evidence. I won't go into detail, but the core functions we found were about 7 integrated in 3 main domains. One, focused on really reducing the entry level for testing. So reducing the barriers, ensuring equitable entry into the testing cascade. Second, really ensures that we have a system that supports trust, autonomy, and tailored engagement over time. And the third, ensured that there was continuity of care. So whether once you test, how do we ensure that you get access to treatment very quickly? And then how can we continue to adapt the system to the different populations that we're trying to serve? And so this gave us like a plan for how we can think about conversations around sustainability going forward. But as I joined the working group, what became very apparent at the very beginning was that sustainability was talked about, but the meanings were very different for the different communities we talked to and for different partners. And these different framings really created tension in the room. So my first task was to help understand what sustainability means from different partners, help determine how that influences sustainability, and how we can then use that to create a strategy for sustainability going forward. So like I said, we did a case study. We drew on the dynamic sustainability framework and used framework analysis, which is a technique that helps you explore perspectives from different partners on a common topic. And then we translated the findings from our study into non-mutually exclusive strategic packages for sustainability of the service. I'll briefly describe how these tensions emanated. So from the core group and champions of the service, sustainability really meant having resources to meet the needs of populations that we're positioned to serve. But that comes in tension with the operational definition of sustainability, which just means ensuring that the lights are kept running. Continue to serve people under the budgetary constraints that exist within the service. And you can see how those two things can become a tension point. But for broader systems partners, sustainability really meant integrating the service across the system so that marginal costs are reduced in a way that benefits everyone and reduces the cost of the service to the system. And this resulted in 5 major tension points. First was that there was an equity-driven vision from the core service, but it faced operational constraints within the operational setting. So, how much can the BCCDC, for example, continue to sustain a service that continues to grow at this rate? But then there was the idea that the innovation identity of the service was facing a challenge with the system's evolution. So across the systems, new on-demand, low-barrier testing services are emanating. And so with GetCheckedOnline being seemingly low-barrier also, what's the unique identity of the service? What really struck us was that, there was a perceived value of the service across the system, but no one really wanted to, give that material commitment to sustaining or scaling the service at the level that everyone said the service needs to go in. The other thing that came very apparent within this conversation was how digital equity is a goal that many people identify as really being want to pursue, but the systems do not necessarily support this goal. So, for example, GetCheckedOnline supports non-nominal testing, but the whole process to actually ensure reimbursement for those services is really a huge challenge. And then finally, as the systems evolve, it needs to quickly adapt to the changing systems, especially with fiscal constraints. And so we created 5 strategic packages that really address this system, whether that involves, becoming a targeted equity-based service, so reducing the footprint of the service within communities that we serve, or using GetCheckedOnline sort of an innovation incubator for different services like, dry blood spots at the provincial level, or, self-sampling, self-testing, but then figuring out how we create adaptive funding packages across the board while ensuring that we pursue the broader goal of systems fit at the end of the day. What became really apparent, and I think it's also becoming apparent in implementation science literature, is the fact that we have to embed economic analysis alongside effectiveness studies. So while we've done a very good job of showing the effectiveness of the service, how can we continue to create an economic case for the service? And this was published late last year, and it's been really cool to see how the Ministry of Health and other systems partners are then using this output to actually inform decision-making within the service. Finally, what we heard from the service was that, others want to learn about a 10-year-old or 11-year-old service and how it has learned from that whole trajectory. And so we looked at the data to explore how sustainability evolves over time. And we spread this out in 4 main themes, where early enablers of the service, including things like the moral imperative to ensure equity, and the idea that relationships really matter the most in creating such equity-based services, eventually become systems constraints over time. And the tipping point for GetCheckedOnline was the fact that, through COVID, there was increased attention, but there was also broader inflationary stressors within the system, so tests became really expensive to process. But also the fact that, sorry, there's some feedback here. Also the fact that, I can't see that, there was inflation within the system, and then there were lots of manual workarounds that the increased demand exposed. All of this resulted in some form of liminality that the system is trying to work through now. And what we've learned is that there's the need to have strategic pauses within the service to formalize responsibilities, formalize governance systems, and ensure that there's a person responsible for different scenarios for growth of that service. And so using that, one of the things we then learned was the need to actually understand how demand was growing on the service. And so we had done preliminary analysis showing that potentially about 10% of tests were over recommendations, where testing occurred more frequently than 3 months, the lower bounds of our testing frequency. And so we wanted to understand what testing trajectories looked like over time. And so we did a group-based trajectory modeling using Poisson finite mixture models to explore how people test once they get on the service. First thing we noted was that the top 10% of users accounted for nearly 40% of the testing. Is this over-testing? Is this indiscriminate testing? And so we built out trajectory models that showed that there were two main trajectories on the service. One, where people tested on average about 1.5 times every 6 months, and then one where people tested about once and then tailed off to about 0.25 times every 6 months. So really what we expected. But for this higher intensity testing group, did this really mean over-testing? We took a look and it was a mix of things. Folks who were in the high intensity testing groups were those who had higher sexual risk. And so it was really consistent with their needs, as it were, for the service. And so high-frequency testing really was risk-aligned. There were some access gaps. For example, people living in the most ethnoculturally deprived communities also were less likely to test. So it's a mix of both. And so at the end of the day, our recommendations were that we need to be figuring out how to educate people more about testing frequency rather than having blunt closures of services in different communities. I want to acknowledge a few limitations. We have a systems focus. So I know that sometimes we might need to talk with community, but this is not necessarily the point of this specific study. There's ongoing studies to do that. There are also the fact that I was embedded within a single case, so this case may not necessarily transfer into other contexts. But our findings have showed that we need to be figuring out systems fit from the very beginning. And that, as systems scale, or this equity-based systems scale, they expose, the lack of equity focus within the broader health systems, and this is something that we continue to advocate for change for. But that sustainability planning has to be deliberate and anticipatory. I'd like to thank my supervisors, Dr. Mark Gilbert, Sophia Bartlett, a whole team of CTN investigators, including Kathy Worthington, Dan Grace, service users of GetCheckedOnline, my DSHI team, our sexual health advisory group, and everyone. Thank you. Yeah.
Okay, great. Thanks so much for a lovely presentation and great graphics. I think many people would love to learn how you can put together such beautiful graphics. I think the main thing is you're highlighting the complexity of, many people have a great idea. It seems like a relatively simple thing. Let's just do a test, get online. And then you're highlighting how complex the actual system into which it needs to be integrated in is. And all these pitfalls. So, and in some senses, it's fantastic to see how you can dissect it all and try to find points where you could intervene. And the other side, it feels a little daunting, like, actually, should we even try these things because the systems are so complex? And I think BC is actually in a situation where it may be perhaps less complex than some other places. So any final thoughts about this in terms of other people who might be here trying to think about these sorts of interventions that if up front you knew about them might have made the path easier?
Right, yeah. That's a very good question. It is daunting work, but it is work that must be engaged with. I think that good ideas, I say this many times, I don't think we lack in good ideas. We have many good ideas. The problem is making sure that they then scale. To do that, what we've learned from all of the work we've done is the need for careful, deliberate planning around sustainability, planning for scenarios where a service will actually do well, and having multi-partner conversations about who gets to bear responsibility for the different scenarios where that service does well. And so some of the things that partners have talked about is now wanting to embed processes for thinking through sustainability, having strategic pauses to see how do we model scenarios for growth of this service, and can we think about ways to fund this in a whole of systems approach. So not just you're thinking about your microcosm, but how can we bring in leverage strengths from different aspects of the system and show that we are saving those different aspects of the system costs because of the implementation of this service. And that's why I emphasize the need for very early on integrating some economists on your trials. It's absolutely important. As much as I found within the study that equity is an imperative and people buy into it, forgive my French, but when shit hits the fan, everybody goes back to the money. And so you have to create that economic case from the very beginning so that people create or know that this is going to be of value to the service or to the system.
I think in similar ways, we always need to remember in our research, the ultimate goal is to change policy, and that is the biggest hurdle. And again, I think that's something that we have to think up front. We do something, we have a great idea, we have a great intervention. Who pays and how do we put it in place?
Absolutely, yeah.
Thank you for a great presentation. I just have about 2 questions.
Yeah.
One of the questions relates to something you didn't talk about. But
Yes.
So in BC, when I teach a course on HIV/AIDS, there's a really nice study that was done, I think it was by BC CDC, where they looked at testing in emergency rooms, and it was going really well, and they actually presented a paper, and it sort of just died out because of COVID. And so it was really sad to see that go, because they actually found people that had never come forward for testing.
Right.
So, and this one, so I guess my question is really around sustainability of getting checked online or programs like that. Just what is the long-term, how do you sustain success in terms of sustainability of your program? You're still in a pilot, kind of a quasi-pilot state.
Yeah.
So how do you move from that into something that's further along?
Right. So it requires a lot of thought. The directions that, first I'll acknowledge that, a number of services were closed during COVID. It just happened to be, the unfortunate result of that context. But in this context, our thoughts are that you need to be thinking about broad service integration, figuring out who gets to be reimbursed. So I think one of the hugest or the biggest challenges for GetCheckedOnline is getting that reimbursement endorsement. So right now, GetCheckedOnline operates a model that is non-nominal, and there's no MSP code to build that to. So one of the challenges is figuring out how can we move this to a system where even though we maintain a nominal testing or non-nominal testing, there's a code that we can build this to, and that we can ensure that we get reimbursement for the testing that's done on the service. I think one of the ways that GetCheckedOnline team is thinking about doing that is integrating with primary care, figuring out how you maintain that continuity of care by ensuring that your primary care physician can access results through GetCheckedOnline, and then we can get the billings for those tests for that or reimbursement for those tests.
Okay, thank you very much.
Yeah, thank you.
Sharon and I always get to share this, and hopefully we will continue to share this going forward for a few more years, because it's a pleasure really to be here to hear the fruits of the work that our fellows have done over 2 years. So it's my pleasure to introduce our next speaker, who is Dr. Shaliza Hulani, who will be sharing her findings from a scoping reviews and qualitative study that seeks to increase HIV PrEP counseling and prescribing among women through provider education. Shaliza?
Hi everyone, I'm Shaliza, supervised by Dr. Tan and Dr. Lutfi for this work. I'd like to begin with a land acknowledgement. This work was done in Toronto, which has long been a meeting home, to many diverse Indigenous nations, including the Haudenosaunee, the Anishinaabe, the Ojibwe, Chippewa, and Huron-Wendat Indigenous peoples. We're here in Winnipeg, which is located on Treaty 1 territory, the traditional lands of the Anishinaabe, Innu, Ojibwe, Cree, Dene, and Dakota, and is the birthplace of the Métis Nation. I've been reflecting a lot throughout this conference and my time as a postdoc fellow on what it means to, what meaningful reconciliation means, and how we've seen how HIV has had immense impact not just on women, but on Indigenous women specifically. And I think we really have to center that in our current and future implementation work moving forward. These are our conflicts of interest. So I'm going to be talking, as Marina mentioned, about two projects. First is a scoping review looking at educational programs for providers on HIV PrEP for women. And the second project is a qualitative study where we interviewed providers across Canada assessing educational needs, barriers, and facilitators. And the third project is something that we are just designing and hope to conduct in the coming year, but I will talk about that a little bit more at the end. So we've seen data that in Canada in 2024, there were more than 2,200 new diagnoses of HIV infection overall, and more than 780 of these were among those born female sex. I'll be using the term female here just based on the data, but in the subsequent slides, I'll use the term women, which refers to inclusive of cis and transgender women. We know from the data that about 59% of infections among those assigned female sex at birth were in the context of heterosexual transmission, and about 29% in the context of intravenous drug use. We know that despite this data, PrEP remains highly underutilized among women in Canada, and in 2022, 2% of HIV PrEP use was among those born female sex. We do know that the science has rapidly changed regarding options available for PrEP for women, not just oral PrEP, but we know that the HPTN 084 data has shown us that we can use injectable cabotegravir every 2 months for HIV PrEP, and we know the Purpose 1 data shows that lenacapavir is also an option and is now Health Canada approved. So this is a prime opportunity to reinvigorate our approach to HIV prevention for women in Canada, and we decided to focus through this work on how we can actually educate providers about this. So the objectives of our scoping review were to evaluate and identify gaps in currently available educational curricula for non-infectious disease providers to learn about PrEP for women. Another objective was to explore educational facilitators and barriers to providing and counseling about PrEP for women. Another objective was to identify currently available provider training initiatives and look for areas for curriculum development. Our scoping review used the ARC-C and O'Malley framework, PRISMA checklist for scoping reviews, and our data extraction was performed by one reviewer, myself, and then 3 team members each were our second reviewer for 10% of the final articles for data extraction. We used reflexive thematic analysis to develop themes from the data, and we used quality appraisal through the mixed method appraisal tool, the MMAT, and we used an 80% acceptable rate for completeness of data and 20% dropout rate. So we searched 4 databases. As you can see here, we specifically included Sanal Plus, which focuses on allied health professionals and nursing. We conducted the search on September 2nd, 2024, using the mesh terms there, but you can see the key concepts around HIV, PrEP, training or education, and then use the terms women and female just to be inclusive. In terms of the inclusion criteria, we included articles on the educational needs, resources, interventions, and other educational content for non-ID providers on HIV PrEP for women published since 2012. And you can see our exclusion criteria there for the articles. I won't read them all out. We also reviewed the bibliographies of relevant articles to identify companion articles, and 2 rounds of data extraction were done. You can see there our PRISMA checklist. We began with more than 2,800 articles and landed at 34 final articles that were from 28 studies, so 28 unique studies. There were just some that published various articles, so 34 total articles. In terms of the study characteristics, you can see that 21 of our 28 studies were from the USA, 6 from Africa, 1 from Australia. In terms of some other key characteristics, 4 of the studies focused on PrEP for adolescent girls and young women. 3 included gender diverse or transgender patients or providers in their studies. 7 discussed PrEP related to the use of drugs among women. In terms of study type, I won't read them all out, but you can see some are protocols, some are qualitative or quantitative studies. Many are implementation science-based and incorporated education as part of their package. From the quality appraisal, just a few points. 6 articles that were qualitative did not have an explanation as to how they arrived at the number of interviewees, whether they used thematic saturation or other methods for this. We had 2 studies that exceeded the dropout rate and 2 studies that did not meet completeness rate. We still included them in terms of our reporting of data, but just make note of these points. So just to go through some of the key characteristics of our studies, you can see that 20 of the studies integrated PrEP with reproductive care or other harm reduction services, which was one of the main findings of the study. 16 identified additional provider knowledge gaps as it relates to prescribing or counseling PrEP to women. 8 talked about the importance of PrEP experts, mentorship, and consultancy models like ECHOs, for instance, as an opportunity to support providers who might be wanting to engage in PrEP work. 7 focused on communication education for providers, whether that was using standardized patients, role-playing, or opportunities to build on that provider-patient communication. 7 discussed other teaching modalities, so didactic teaching, shadowing, using animations for teaching, or take-home assignments. 5 discussed the importance of integration of electronic medical record prompts, templates, and optimization of the electronic medical record so as to be able to have these conversations with women. 4 discussed the importance of the need for ongoing training for providers. 4 incorporated sexual health and STI education for providers. Only 2, surprisingly, actually talked about cultural competency training, which was quite shocking for us. 1 used provider algorithms, and 1 only discussed the definition of intimate partner violence and incorporated IPV education for providers. We built 6 key themes from the data extraction. I'm not going to read them all out here, but you can see kind of how they map onto the findings that I described on the left-hand diagram. There we go. So from this, we built a model called Rest Chic, or Stay Chic in English, an integrative educational module for healthcare providers on HIV PrEP for women. And what I kind of want to point out is you can see that one part of that puzzle in the top left is review of the PrEP guidelines, or really that content knowledge. You can see that all the other aspects of the puzzle really talk about the other pieces that we have to incorporate if we're going to effectively integrate education for providers on PrEP for women. From our study, there was a rich diversity of provider-level educational interventions, often harmonized with existing services or harm reduction services. And there was a key emphasis on the use of standardized patients or case-based scenarios so as to help with teaching provider communication. Limitations of this was that many of the studies focused on cisgender women. There was underrepresented groups. We didn't discuss or find much from the studies about different teaching providers related to education for counseling about PrEP to different patients of different ethnic groups, indigenous women, women who use drugs, or women who may engage in transactional sex. And there was limited geographic locations from the studies. So we then sought to ask, well, what about in Canada? So we conducted a qualitative study to explore the facilitators, barriers, and unmet educational needs relating to HIV PrEP care to women among healthcare providers from disciplines that might not have been traditionally engaged in PrEP delivery in Canada. So we conducted this qualitative study by recruiting from our professional networks, using purposive and snowball sampling. Our inclusion criteria were physicians, pharmacists, nurses, NPs, or residents in their final year of training, and providers who've either previously worked in or currently work in healthcare facilities in Canada, providers who might have already been prescribing PrEP, might be prescribing PrEP but want to expand this to women, or have never prescribed PrEP before, and our interviews were conducted in the English language. We use the COMBI framework for development of the semi-structured interview guide, which posits that capabilities, opportunity, and motivation drive behavior change. And our coding was performed until thematic saturation was reached. We used constructivist grounded theory and constant comparison analysis, and our participants each received a $50 honorarium. So we had 29 total participants thus far. The study is still underway. We had gender identity on 28 of these participants, 20 identified as women, 7 as men, 1 non-binary individual. You can see a range of practice settings there, but predominantly our providers practice in an urban setting. In terms of province breakdown, we had 15 participants in Ontario, 5 in BC, 3 in Quebec, 2 in Manitoba, 2 in Saskatchewan, 1 in Nova Scotia, and 1 in Newfoundland. And you can see there the breakdown by provider type as well. So 10 family doctors, 6 pharmacists, 5 OBGYNs, 3 nurses, 2 endocrinologists, 2 psychiatrists, and 1 in addictions medicine. 2 of our participants were in their final year of residency training, and then the remainder were at various stages in their career. And then just to highlight some key themes from this work. So there's 5 key themes to discuss or share. So first is that provider misconceptions of HIV epidemiology and structural barriers perpetuate gender-based inequities in PrEP uptake. And we had many participants comment on just a lack of understanding of the epidemiology of HIV in Canada as it is today. So here a family medicine physician is saying, honestly, I think just understanding the stats, because very few people know that a third of new diagnoses, specifically in Ontario and Canada, are in heterosexual cis women. The second theme was that the nature of provider-patient relationships impacts the willingness to discuss PrEP with women. So many talked about the relevance of PrEP to the reason for their visit, the relevance to their patient population, and specifically also that aspect of continuity of care. So here a hospitalist is saying, I know what to give as it relates to PrEP, but I'm always thinking when the patient is discharged, is there a place where they can obtain this medication long-term? So being aware of where to refer patients to or certain referral pathways can be helpful. The third is that providers expressed interest in communities of practice to support both PrEP prescribing and allied health-led interventions. And so this is a similar finding to what we found in our scoping review, that having access to an expert or someone to lean on can help support these additional PrEP programs. Fourth, provider education has to address women-specific concerns or questions that women will bring to a visit. So here an OBGYN is saying, because I'm in charge of pregnant women, a lot of them fear the impact of the medication on the baby. And a nurse is speaking specifically on injectable PrEP in that second quote there, saying, I don't know if injectable PrEP has implications on menses, on fertility, and do I need to be off of the medication if I'm trying to conceive? So being able to answer those questions for women and having that knowledge as a provider is important. Finally, education on HIV PrEP has to be decoupled from HIV education and include public awareness as well. And so here a pharmacist is saying, I don't think women have the knowledge of what PrEP is. I think in the MSM community, yes, they do, but I don't think women have heard of it or that it's even socially acceptable. We had a few sub-themes related to education. I won't read out all the quotes, but I'll just give some highlights from the sub-themes, which is that we asked providers if we had to design an optimal educational program, what would that look like? And so some of the key components is that we have to train providers on communication skills related to discussing sexual health, which is similar to what we found from our scoping review. We have to tailor education to diverse providers, provide compensation for additional work and incentivize learning, provide practical tools for clinicians, address additional considerations that may arise in the era of injectable PrEP, and we have to start this earlier in medical training. So in conclusion, we found from our qualitative study that provider and public understanding is limited as it relates to HIV PrEP for women, and provider assumptions and misconceptions on the HIV epidemiology in Canada impact that. Media narratives on PrEP being an intervention for GBM also impact that, as well as ongoing gender inequities in how we address sexual health. One output of our qualitative study is development of a provider-specific summary of opportunities and challenges. Limitations of this work include the geographic representation across Canada and limited specialties included. And our next steps is a project that we've titled WISE PrEP, a women-informed support tool and educational resource with provider education on PrEP, which we've recently been awarded the CTN Plus seed funding for, to develop an educational resource with a tool for providers in discussing and counseling on PrEP for women. Thank you to my supervisors, Dr. Tan, Dr. Lufi, Dr. Al-Kadragi, who's my co-supervisor at the University of Dundee for the scoping review, all of our team members here, and our funding supporters as well. Thank you.
So thanks very much, Shaliza, and I think that this work clearly aligns with a lot of the work that Network as a whole is trying to do at this time, is bringing PrEP to the people that need it most and trying to find the mechanism that suits those populations best. And so part of our implementation science approach to this problem. Are there questions for Shaliza?
Hi, thanks. That was very interesting. I have a question, might be like jumping the gun a little bit for you, but you talked about kind of your plan to develop this training, and I'm wondering kind of how you're thinking about integrating different guidance across provinces, especially when it comes to women, from like the different provincial guidelines.
Yeah. Thanks. We're just in the beginning stages of designing it, but I think the first step is going to be to put together some sort of advisory board, including healthcare providers as well as community members, to help design what would be some sort of tool that could be translatable to various different clinical settings, especially knowing care is different province by province and in the territories as well. So I think that advisory board should help with incorporating different opinions and perspectives on how to optimize an educational resource. So would love to collaborate or chat.
Yeah, I was just primarily thinking about like who is covered for PrEP use and who isn't, especially I'm from BC, so I know that there's definitely limitations around women specifically for when they can be covered by PrEP. But yeah, thank you.
Thank you.
Great. Thanks, Shaliza. And I am very thrilled at how many people have now joined us. And I'd like to take this opportunity before we have our last speaker to make sure that everyone is aware of the new and invigorated CTN. We now call ourselves CTN Plus, and we really are Plus. And under Marina's new leadership, we are new and invigorated. We had 3 days of wonderful meetings before CAHR, where we had incredible engagement with lots of our young investigators participating and promoting our study ideas as we move forward. So I'd invite any of you who are interested in joining the network, please contact one of us or go onto the website, see what we do, and see what it means to be involved. And for those investigators who get accepted as a CTN researcher, you would have the opportunity to apply for having a postdoctoral fellow work under you in subsequent years. So keep that in mind. So for our last speaker of the day, we're going to have Kathleen English, together with co-presenter Wayne Campbell from the Ribbon community, are going to share the importance and value of community engagement in administrative database. I welcome you to the podium.
Hi everyone, good morning. My name is Kathleen Inglis. I'm a CTN Plus postdoc, and my supervisors are Dr. Robert Hogg and Dr. Catherine Worthington.
I'm Wayne Campbell. I'm a person living with HIV and one of the peer researchers associated with this project. We have no conflicts to declare.
So our presentation today is based on our experience conducting a community-led research project using administrative health data. So we therefore don't focus at all on our administrative data results, but if you are interested in that, please see poster 35 in the Epi and Public Health section, where Wayne and our teammate Miriam are going to present some of our findings. Active participation by people living with HIV as research partners has been pivotal to the history of HIV research and has promoted community-based participatory research in health studies more broadly. Yet now, data science, like administrative health data research, is becoming more prominent in many fields, including HIV, which has largely circumscribed HIV community members. Administrative data research is defined by using routinely collected data generated at each encounter with the healthcare system for administrative or billing purposes. It therefore brings two important shifts from traditional community-based research. So data are typically not originally collected for research purposes, and the opportunity for collaboration comes after the data are already collected. It therefore causes a renegotiation of the role of community members. So we therefore explored where community-based research figures into the possibility of more democratic and valid data science. So our goal is to imagine and foster an alternative whereby administrative data research is reframed from a process of data extraction to an authentic collaboration with the people who are being studied within the data.
We brought together an extensive team of people living with HIV as a peer researchers. We have HIV clinicians, epidemiologists, and community-based researchers, and we are based in British Columbia. We formed a peer-driven project called HIV and Engaging. This artwork presented here is created by one of our peer researchers, Peggy Frank. The forest of diverse trees symbolize the strength and solidarity among the HIV community and our team members. Our project methodology entails two nested elements. The first element, next slide.
Thank you.
The first element entails doing administrative data research using a study called COAST, a linked data set housed in the BC Centre for Excellence in HIV and AIDS, and the PI is Dr. Robert Hogg. COAST assembles data for all eligible adults living with HIV in BC who are taking antiretrovirals, and a 10% sampling of BC residents from 1992 to 2020. The peer researchers wanted to examine the reoccurrence of cardiovascular events for people living with HIV compared to people without HIV. We are all older adults and long-term survivors who have had cardiovascular disease or are concerned about it. And we identified this topic as an important to us personally and to the HIV community.
And the second element is inspired by ethnographies of citizen science and entails qualitative analysis of our research process while we were doing it. So we did this through collective participant observation and through reflection and dialogue, which we called Gathering Wisdom. It's represented in this artwork here, also created by Peggy Frank, which shows our team hopping into a space exploration capsule and zooming around, looking at our solar system of research from all sides. As a social scientist, my role was to focus on this qualitative analysis, which our presentation today stems from. So while community members working in the space of health and medicine research often confront varied technical barriers, the space of administrative data research is uniquely complex. Uneasy relationships surfaced between self-governance among peer researchers and existing systems and procedures of administrative data science, which we conceptualize as tensions. Yet creative alternatives arose as well, which we conceptualize as transformations.
Something alien for us peers was lacking control over the data that was produced and having to, in a sense, work backwards. As the first quote here indicates, it was a shift to have us first learn what we could be known from the data before coming up with the research question. And the second quote speaks to people's struggles with being conceptually bound to the secondary data born from disease classification and coding systems and billing structures. It was through several user-friendly presentations by our epidemiologists on our team that we gained a strong understanding of what could and could not be known to help create a research question. This slide shows Peggy with our team just out of frame, collectively drawing a cyclic graph, or a DAG for short, a tool that is widely used in epidemiology. The DAG activity was key to early determination about how to best make use of the data that we're bounded to. It was through the peers' personal stories and the stories of the people that they knew that relevant and missing variables were identified, and that variables were identified accurately, grounded in lived experience. We'll give a specific example shortly. The reference at the bottom of this slide here is a plug for our now published article about the value in engaging people with lived experience in DAGs and how to do so.
Another adjustment for the peers was not being able to see or know how the data are made on the ground. There's a socio-structural and institutional context through which administrative data are made. That is, data are shaped by human beings and the everyday realities of staff and clinicians working within healthcare settings. And there's a degree of not knowing whether the coding reflected what transpired or the full picture. For instance, physician reimbursement schemes may influence how healthcare visits are coded. Recording of healthcare visits may be partial. For instance, clinical staff or providers decide on the diagnostic code for a visit and may not record secondary conditions. Also, the degree of code specificity and thus data specificity may depend on the coder's discretion, as well as norms of the care setting. Entering more specific codes requires more time within documentation-heavy workloads of staff and doctors at busy clinics and hospitals. Some healthcare interactions are made invisible. For example, like a peer researcher explains here in this quote, if an encounter wasn't billed for. So not knowing exactly how healthcare visits were coded and why posed one challenge when our team wanted to look at how often participants' first and second cardiovascular events were of the same type. So if someone was having a stroke at first and second event, a myocardial infarction, and so on. It turned out that there were cases where an individual was coded with having more than one type of event within their same hospitalization. So data from the same person about the same moment suggested different or conflicting realities.
These are complexities epidemiologists regularly work through. For us peer researchers, these were not simply regarded as research limitations. Rather, as the quotes show here, absences and unknowns were deeply felt by us peers. And we see ourselves and our HIV-positive peers not only in the data, but reflected in the numbers.
So tensions were not simply deterrents, but were opportunities to transform ways of doing research. For instance, by challenging deficit-based norms. Notions commonly used in administrative data research like mortality rates, poor health outcomes, and risk factors were activating to peer researchers. So it was essential to frame our research on strength. Instead of recurrence rates and mortality rates, we framed our research around recurrence-free survival, meaning survival after a cardiovascular event without experiencing another event. Inverting the focus was familiar to peers and community-based researchers, but it wasn't innately conducive to epidemiological ways of doing things, including statistical modeling. So as these quotes show, it tripped up epidemiologists on our team and required some extra mental steps. The most commonly used statistical models are designed based on modeling the relationship between a determinant and an outcome or event. The outcome is usually a health condition or an event like a heart attack or death, which is coded as 1, and no outcome or no event is coded as 0. So because our outcome of interest was survival, so no event, this would require reversing the standard coding scheme, which methods like survival analysis and Cox regression are not able to meaningfully handle. So regular statistical models are therefore inherently paradoxical to a strengths-based approach. So this means that we can frame discussions in a strengths-based way, but the presentation of the statistical results themselves cannot follow suit.
Another way us peer researchers pushed the envelope was by compelling a reconsideration of the conventional administrative data definition of primary care engagement. When developing the DAG, we identified our primary care as a protective factor for reoccurrence-free survival. One of the peer researchers asked our group, how is primary care provider identified in administrative data? It was explained to us as namely family doctors. We realized that a large segment of the medical providers that we see are not accounted for in this administrative data research using the concept of primary care engagement, namely our HIV specialists. As these quotes describe, HIV specialists have been an important, if not the most important, healthcare provider for many in our lives. We have been fortunate to have access to providers in comparison to the HIV negative population who may struggle relatively more access to healthcare providers, particularly under the healthcare system crisis of the last 10 years. We therefore might see our HIV specialists for non-HIV specific reasons rather than going to urgent care or to the ER. People living with HIV may have a stronger relationship with their HIV specialists than their GP. Another reason why specialists may be treated as primary care providers in this model. Our team's HIV specialists shared these sentiments as well. As these quotes show, we recognize, of course, that this may not be a universal experience for people across BC, and it was therefore the basis of exploring a pattern of primary care engagement.
Also, primary care engagement is conventionally operationalized by notions of attachment and continuity of care, which are framed by a certain number of encounters within a specific with a specific provider or clinic within a certain time frame. As one example, the BC Ministry of Health has a definition that focuses on visits to a primary care provider or practice within the past year. However, peer insights made it clear that realities were much more complex. They shared that they regularly see a combination of HIV specialists, GPs, nurses, and nurse practitioners, and that the frequency and combination varies across people and changes with one's health status, age, so many things at a moment in time. We therefore reapproached this concept and deviated from other definitions by instead using more open-ended incidents of engagement as an exposure rather than cutoff points. So from these examples, we see how peers shaped the research in ways that otherwise may not have happened with a team of academics alone. So our process-related research contributes first to social scientific theory about health data-driven research. Critical scholarship has focused heavily on the exploitative and top-down dynamics of data-driven knowledge production, and we hear much less about the instances of agency and possibility involved. Owing to our community-based approach, we therefore provide a nuanced understanding of how people, namely peers, engage with data-driven research at the same time that they unsettle or transform traditional ways of doing things. Administrative data research remains obscure to people who aren't of this world, so documenting and analyzing the tensions and possibilities that arise can help to open up dialogue and collaborations. And secondly, we challenge the popular metaphor that administrative data studies are like pulling up fish, as if data were fixed objective entities. Selecting data, putting bits of data together, and repurposing data is full of subjectivity and interpretation, and we argue that insights come from carefully crafting the lure, so to speak, which is best done with community members. The growth of data science research in many fields, including HIV, somewhat reshapes the landscape of research activism. Yet, peer researchers feel that it's still a terrain for meaningful community leadership. There were compromises, but as scholarship on community science has argued, total agency and self-governance from existing paradigms in any realm is not possible. Rather, what was important to the peers was learning where the opportunities to innovate existed and being given the space to do so.
In closing, we urge researchers to engage people with lived experience in administrative data HIV research. We've been seeing more examples of such initiatives, which is great, including the CTN plus Strive project. And we hope that our project helps to contribute a new imagery for administrative data research for the benefit of people living with HIV. I'd like to take this moment to thank all of our funders. A big thank you to my fellow peers and to our amazing team.
And a big thank you to my CTN Plus supervisors, Dr. Catherine Worthington and Dr. Robert Hogg. And this QR code in the bottom there leads to our project website if you would like to learn more about our project. Thank you.
Thank you both. It's really, really interesting presentation. We have time for questions, so if anyone wants to come up. So I guess in the meantime, lots of other things are happening with data, and thinking about AI and how this could even get more complex in terms of bringing together community with respect to how influencing both questions that we might pose to AI and the interpretation of the work that comes. Did that come up at all in the discussions around in this project, or it seems like the elephant in the room that's coming down, barreling down at us very quickly?
Not yet,
Yeah.
but it is an interesting concept that we will keep in mind.
Yeah. I thought the DAG work was really fascinating, because DAGs are always really difficult to construct, and I think important to take all those perspectives in context. So I'll look for that article. I see a question coming behind me.
Hi, good morning. Sorry, hopefully I'm not taking up too much space asking another question. So I'm a community-based research coordinator, and so I do a lot of training and capacity building, and I'm very process-focused, so I love to see this. And I also wanted to ask both of you, kind of reflecting back on the training process, just to know a little bit more about how you built in kind of the training, because you clearly did, but kind of how you built it in as you went along. And I think the DAGs are especially interesting, and I want to talk to you about that more later, Kathleen. But if you could just talk a little bit more about the training, and also, Wayne, your personal experiences in it, what worked really well, what you guys maybe had to shift on. Sorry, that's a bit of a big question, but.
We started off our training by learning what data that we had access to. We needed that grounding first. And we started looking at, we have this information, what can we get from it? What are the databases, what information does each database contain? From there, we knew that we can build our research questions, but we had to also do trainings, how to use a DAG, and we did 2 or 3 trainings, and it got to the point where we needed to basically consolidate all of our training materials into a booklet because we were having new people coming in. And so we just couldn't keep repeating it, but we started making training modules and resources for those that come in again. And as we continue to expand this project, trainings will continue on an as-needed basis.
Mm-hmm. Yeah, thanks, Zoe. We'd love to share stuff with you. But yeah, we our materials and documents and training modules, they got technically more progressive, or progressively more technical over time. So we started with an introductory booklet, which was just plain language explanation of the COAST study. And then we did a series of PowerPoint presentations, and then we printed all of these in a font that the peer researchers wanted, and we mailed them out. And the peers said that they continually referred to these. And we printed out the DAG tutorial as well. Yeah, and also, it'd be nice to create a knowledge hub. We were talking with Dr. Liz King and Amanda Youngman, who are doing community-engaged admin data research, and they also have training materials, so it'd be nice to amalgamate all these things.
Yeah, definitely. Okay, thank you.
Sorry. I just have one comment, and or maybe a question. So I think there's a really nice paper that you're working on this qualitative work, right? But which I think is very useful. But I really love the artwork that has been put in that was part of this project, and I would like you to comment in terms of the value of art, in terms of this work, and also just in terms of future work that's in this area.
Thanks, Bob.
Thank you.
We'll be sure to include art in all publications. I'm trying to find Peggy's there. Peggy!
Thank you, everyone.
Always good to end with good art. Could I think we have another slide. I just want to close because I realize we're moving into a new next session. Can I have the funders slide, please? Yeah. And just to say again, I think it's really astounding to see the variety of projects that are being conducted by our CTN Plus fellows and their stellar presentations in terms of graphics and conveying the information that they've worked so hard on over the last year, and really look forward to seeing these progress over the next year. And with our new slate of postdoctoral fellows, it's a really broad scope of research support, and I think it's the real value of the network that we can integrate various different types of research that can inform us all about the other research that we're doing, regardless of whether it's basic clinical sciences, epidemiology, or social science work. It all has value, and integrating the peer perspectives and the community perspectives, I think, has come through in all these presentations, and it really is reflective of where CTN Plus is going. So to conclude today's session, I really think we could not support the slate and large number of postdoctoral fellows without our sponsors. Over the many years, we've had this stalwart, continuous support, and they've stepped up again and stepped up to reach the funding levels that are required now by CAHR. And so we really wish to thank CanFAR, ViiV, Gilead, and Merck for their ongoing support of the program, which complements the CAHR that funds our network. And I wish you all a fabulous day, this full day of conference. Really exciting materials are coming up. So thanks again for participating in such great numbers.